Welcome back, everyone, to our Crosscast series featuring RhAPP, GHAPP, and the SDPA, talking about obesity and IMID. This series is different than anything we've really done before, and it is wrapped around this initiative of boot camps that we are taking nationally across the country to each and every one of these specialties APP conference. So gastroenterology, GI, dermatology, and metabolic. We're going to each of those conferences with this concept, and it's been great so far. This time we're talking to you about from insight to action, practical strategies to improve outcomes for our patients with obesity and IMIDs. This is the third in the series of podcasts that we've talked about and really dives into what's important. How can we make a difference in these patients' lives and what we're doing on a day-to-day basis? My name is Amber Blair. I'm a dermatology PA with SDPA and representing DermCast today, and I'm gathered around by my great colleagues, and I'll let each of them introduce themselves.
Hi, I'm Jennifer Jeremy. I'm a physician assistant with the Gastroenterology department at Brigham and Women's Hospital, and I'm excited to be here with my colleagues so that we can discuss really building that team to manage these patients across a multidisciplinary space.
My name is Naomi Amudala, and I'm a nurse practitioner. I work at Penn Medicine in Philadelphia, Pennsylvania, and I'm working rheumatology, so I'm representing RhAPP today.
My name is Jennifer Mackey. I'm a nurse practitioner at the Cleveland Clinic Bariatric and Metabolic Institute. I work specifically in bariatric surgery and obesity medicine, and I also work with my GI colleagues and rheumatology colleagues to help all of our patients with obesity.
In our previous episodes, we really focused more on the epidemiology. We talked about pathophysiology of the disease, and now we're turning to talk really more about real world. What can we do in our clinics, from engaging to compassionate conversations with these patients, to offering referral to other members of the healthcare team that's providing care for these patients with immune-mediated inflammatory diseases? How can we really put together a strategy to make a difference?
That's a great question. So first, we want to start off asking our patients, what do they want? What is their goal for treatment? What are they looking to do? My goal for you is not going to be the same for yourself. You might not only be interested in weight loss and how it relates to your inflammatory disease. You might be interested in being able to hang out with your grandkids, less joint pain, less fatigue. I need to figure out, exactly what motivates you in order to do that. And then I can also help as far as medications and pharmacotherapy with that. So education plays a vital role in treating our patients. They need to understand that having obesity and inflammatory disease are related. Obesity is pro-inflammatory, and the worse their obesity is, the worse disease process they're going to have with their immune-mediated inflammatory diseases as well.
Yes, and that kind of plays into the conversation of shared decision-making and really getting everybody on the same page and offering some of these options. And what are the patient's goals? What are your goals? And you need to find something, a place to meet in the middle for their treatment regimen to be successful.
Exactly. And educating the patient on our mutual goals and working together with the other disciplines like GI.
Talking about educating patients on things like systemic inflammation and the role that it plays in their disease process, how do you go about having this conversation with your patient in a way that they can really understand the impact?
It's funny because I'm with my GI colleagues, and you've all been talking about this for so long, and this is somewhat new in rheumatology. So I think it starts with a very basic understanding that we're talking about weight loss today, not for cosmetic reasons, but for optimal disease control. And that is, I think, a very new concept for a lot of people. And you have to think about, too, different cultures look at body image differently. And so I think there's a sensitivity that you have to approach with each patient, but really explaining we're not conforming people. We're really trying to help you be as healthy as you possibly can. So I always like to talk about inflammation like a fire. So there is a fire going on in your body. From a rheumatology standpoint, it is eating away at your bones. It's causing erosions. You can see it sometimes on x-ray. What can we do to put out that fire? And there's a lot of different tools that we use, right? So we use medications. We use non-pharmacologic therapies like weight loss and diet. And that's when we can talk about how obesity kind of drives inflammation and how we know that now. And so that we know that obesity reduces your response to treatment, but it also drives that inflammation. And so helping them understand that and understand kind of why we're having this conversation, I think that goes a long way. I've found, I've been doing this for 16 years, and I found that if patients don't understand your rationale, they're not going to follow with the plan. So it's really important to go back to that shared decision-making to bring everybody kind of on the same table and level set, make sure we're all on the same page here.
I agree with you. In dermatology, very similarly, in general medical dermatology, having conversations about obesity is kind of new.
Yeah.
And coming up with good ways to incorporate these conversations in order for the patients to understand the importance of the role that it plays in their disease process from a skin standpoint, too.
Right.
It's just a different platform.
Yeah.
When you're talking about obesity with your patients, do you feel like APPs in general have some barriers to that conversation? And if so, how do you overcome those?
Sure, absolutely. I mean, I think, we all tend to, whether it's GI, derm, or rheumatology represented here, but across disciplines, we tend to sort of stay in our lane, ask questions that are pertinent to that specialty, to that disease state that the patient's there, and not really looking at the whole picture of the entire patient. And I think some providers, simply just don't want to go there. They don't want to maybe open, quote unquote, that can of worms, or they perceive it as not being within their specialty. So therefore, they're not going to invite that conversation. I think the other kind of unique thing to discussing obesity is because of the stigma around weight and perception that it is their fault. And, bringing that up, could get a patient that's eye-rolling, saying if one more provider tells me if I lose weight, all of my problems are going to go away, then they, in terms of shared decision-making, they're deaf to you, right? At that point, they're not hearing what you're saying. So I think one is just when we know what those shared goals are and educating them on the fact that, look, this is not your fault, it's not your choice, but there are things that we can do to work at making, the underlying condition better, and again, where are they at in their disease course? Are they acutely flaring or not? So definitely there are challenges both on the APP side as far as inviting that conversation, but also the receptiveness of the patient. And I think the first step is, as we've already said, educating them on the bidirectional relationship between inflammation and obesity, but also just reinforcing that there is no stigma, we are not blaming you, and we're here to help you as an entire person.
Make it less about the weight.
Right.
So in bariatric surgery, post-bariatric surgery, we talk about weight resistance. I don't talk about weight resistance training in weight loss or in body image. I'm talking about bone health, because now you've had this malabsorptive surgery. So now we have to preserve the bones. And so instead of saying you need to add weight resistance training 2 to 3 times a week, in addition to understanding how much protein and fluids and things like that you have to get, now I'm asking you to do weight resistance training. But if I say, why? If I say this isn't for your weight, this isn't for body image, although it will help with that, this is actually for your bone health and to preserve your bones and prevent osteoporosis.
And that's when those trusting relationships come into play. The more the patients trust you, the more of a relationship you have, and the better you are at articulating those messages, the better they can receive them and get their buy-in too.
I think we're all probably doing this, but just to say that these conversations have to be approached with empathy. It's easy for me. I don't have swollen joints. So it's easy, getting up and walk for 30 minutes. Well, it's easy for you to say that because your joints are fine. But if you talk to somebody who maybe can't afford healthy food or is just living on fast food because that's all they can do when they're running from job to job to job and they're just kind of trying to get by, I think that has to just be acknowledged. And I'm sure we all do that, especially as APPs. I think we're great at that. But just acknowledging the challenges that they have and saying, I know this is hard for you. You're worth it. You deserve this. You deserve this good health, and I'm going to help you get there.
We talk about approaching these patients with 4 pillars, including diet, including activities and exercise, including really addressing the pharmacological potential and embracing the surgical potentials in a day and time where all of the pharmacological potentials are increasing and GLP-1s are all the hot craze. Now that we have different specialties sitting around the same table, I'd love to go around and go, who is prescribing these medications? How comfortable is it in your specialty? And I'll start. And in dermatology, it's sort of the outlier if you are going into a room with a patient with obesity and really diving into that component of what we're doing for these patients. So these are not drugs that I am prescribing, but I'm so excited to see these patients coming in that I've been taking care of for years and years and years with psoriasis that are now 20 pounds lighter, 30 pounds lighter. So I'm seeing on the other side, and it's so exciting to witness. I'm sure that you're very comfortable in the GLP-1 space, but how about you ladies?
So I think in GI, we now have an indication in the GI space to utilize GLP in particular for MASH with fibrosis. So I think the comfort level will increase amongst GI providers given the new indication. There also is the role for some GI or endoscopic motivated procedures for weight loss. And with that, you have to offer a comprehensive weight program. But apart from sort of these very specific weight management programs or even hepatology, how do you get sort of your community GI practitioner comfortable having that conversation? And I think it depends, as the patient coming to you with, my doc sent you here because I have a fatty liver with abnormal labs and you've done the workup and now it's time to figure out how to treat them, versus I'm here for a completely unrelated condition, whether that's anything from acid reflux, which can be BMI dependent, to, or a contributor, I should say, to inflammatory bowel disease, and they didn't come in with the expectation of having a weight conversation or weight management conversation. So in that lens, to your point, how do you now invite this conversation in a space that you're not historically doing? I think so in GI, I think our comfort level may be a little bit higher because of our other indications, but it's still not used widely.
Yeah, in rheumatology, I have never prescribed a GLP-1. I see that tide changing. I can see that that's going to be more and more. I think rheumatology, we have to own that aspect of the patient's health as well. I do foresee, it's like in rheumatology, every medication that we try to get, we have to get prior auths for. And so this is going to be another medication that we add to that list. And so that's also a partnership between pharmacy, because our pharmacists are not used to doing all of that specifically for GLP-1. So I think it'll be a learning curve for everyone.
Your dermatology colleagues can help with that because we get prior authorizations for like 75% of what we prescribe right now. There's a process and a method. Thinking about prior authorizations, what's the challenge there? Time. Time is everybody's rate limiting factor across the board, certainly is in my space in my clinic. Talking about workflows, what type of changes can APPs make to start to integrate addressing obesity in the clinic and making it a part of the conversations with these immune-mediated inflammatory diseases?
I think, first of all, you've got to recognize that obesity is a disease. How many patients have you gone into the room that have overweight or obesity and it's not even on their chart? There's the diagnosis code isn't even on their problem list. We have to start there. Get the patient used to hearing you have class 1 obesity, class 3 obesity. Get them used to talking about it in relation to everything else that is going on. That one independent factor isn't to blame for your psoriasis, rheumatoid arthritis, IBD, skin plaques, but certainly bringing up the conversation. And one of the areas that I would implore all practitioners to start with is just by starting with the height and weight so that you can calculate their weight and their BMI.
That's a great simple point. And for all of our listeners out there that are really just beginning to integrate obesity management into their clinic, what first step outside of getting a weight can they start doing as easy as Monday morning that starts to change the way we're viewing these immune-mediated inflammatory conditions and obesity together?
I think if you're listening to this podcast on your drive in on Monday morning, you're already halfway there. Honestly, I think it's education of patients, but it's also education of APPs, maybe especially in rheumatology, just becoming aware of that and then integrating that into our conversations with our patients. So if you had the opportunity to go to the boot camp, or if you're now listening to this podcast, hopefully that's on your radar now to start talking about that.
Agreed. And that's something simple. We need to set realistic goals that we can achieve and make a difference, and not just talk about things in a broader spectrum. A big thank you to all of you for sharing. I appreciate it. It was great to talk to you all. And it was great to get so many specialties around one table looking at one thing from different vantage points.
That's a wrap.